Hey Rebel EM subscribers and members. Today we're going to be talking about norepinephrine. How high can you go? So I put this poll out a few days ago, and it is, what is the maximum dose of norepinephrine you will use? And on X, over half of people said there's no maximum. On YouTube, the majority of you also said there's no maximum. Now, to talk about this, I have to start off by saying there are no randomized clinical trials on maximum dose of norepinephrine, but I did pull 5 papers that do discuss this issue. So the first one, with the PMID number at the bottom, survival after shock requiring high-dose vasopressor therapy. This was a retrospective study, 443 patients, and they defined high dose as greater than or equal to 1 microgram per kilogram minute. 17% of people survived at 90 days despite requiring this high a dose. That's 1 in 6. 8% ended up having digital necrosis. Now, the highest dose they actually reached was 1.8 micrograms per kilogram minute, and the median duration in survivors was 122 minutes. This was 183 minutes in non-survivors, so 2 to 3 hours. Stress dose steroids were associated with increased survival. The second study I pulled was high-dose norepinephrine treatment, determinants of mortality, and futility in critically ill patients. Another retrospective study published in 2013, 113 patients with circulatory shock, and the way they defined high-dose norepinephrine was greater than or equal to 0.9 micrograms per kilogram minute. 34%, 1 in 3 survived at 28 days. The highest dose they actually reached in this study was 2.91 micrograms per kilogram minute. Now, one thing that they concluded was that the norepinephrine dose nor duration were predictive of 28-day mortality. The third paper I pulled is norepinephrine, not too much, too long. PMID number attached at the bottom. This was published in 2015, another retrospective study. 324 patients with septic shock. They defined high-dose norepinephrine as greater than or equal to 1 microgram per kilogram minute. The highest dose they actually reached in this study was 1.4 micrograms per kilogram minute, and the in-hospital mortality reached 48%, which means just over half actually survived. Now, I pulled this as a case report, and I'm not saying that a case report is a higher level of evidence, but just wanted to prove a point here. Should the norepinephrine maximal dosage rate be greatly increased in late shock? So this was a case report, one patient in hemorrhagic shock from a blast injury, and they survived with no perfusion-related organ damage. These authors actually reached 22 to 30 micrograms per kilogram minute for a total of 4 hours, as you can see in this graph. They were at pretty extremely high doses of norepinephrine, and the patient ended up doing very well. The last paper I pulled was outcome of patients with septic shock and high-dose vasopressor therapy. Now, this was published in 2017 as the most recent paper on the topic. Again, another retrospective study, 106 patients with septic shock, and again, they defined high-dose norepinephrine as greater than or equal to 1 microgram per kilogram minute. 40% survived at 28 days. The highest dose they actually reached in this study was 2.3 micrograms per kilogram minute, and the median duration in survivors was 84 hours. There was a 5.7% digit and limb necrosis rate in this study. So if we summarize all these studies, the highest norepinephrine dose that's documented in research is anywhere from 1.4 to 2.91 micrograms per kilogram minute, and then the one case report that got all the way up to 30 micrograms per kilogram minute. If we look at survival rates, it's anywhere from 17 to 52%. And if we look at the duration in which people were over that 1 microgram per kilogram minute, it was anywhere from 3 to 84 hours. And then the studies that did report on digit and limb necrosis, that rate was anywhere from 5.7 to 8%. So a couple of things about this. So I am certainly not advocating that we should be raising the dose of norepinephrine. And as a matter of fact, it should be the rare time that this happens. But if you do see that you're having an increasing dose and you're getting above that 1 microgram per kilogram minute, it's time to start assessing causes. First, make sure you have an A-line and that A-line is working for accurate pressure. Put an ultrasound on the chest and look at the left ventricular function. Does the patient need addition of inotropes? Also, with the ultrasound, look at right ventricular function. Does the patient need inhaled nitric oxide to reduce afterload on that right ventricle and inotropes to support function of the right ventricle? Electrolytes. So I only have calcium listed here, but potassium also can be the great masquerader. Are there any electrolytes that we need to either replace or we need to shift the patient? In sepsis, I can't tell you the number of times we didn't have good source control when we thought we did. The patient had developed some type of abscess intra-abdominally. So maybe consider CT, chest, abdomen, and pelvis in the cases, again, that are very rare that you're having these escalating doses. If you have acidosis, correct this with a bicarbonate drip. Maybe you start CRRT or dialysis to correct this, but make sure you correct acidosis because we know pressors will not work as well when the patient has acidosis. If the patient's on mechanical ventilation and you have them on Precedex or Propofol, maybe consider changing to a different agent because both of these can actually cause hypotension. And then the last thing to consider is adrenal insufficiency and replacing supplemental corticosteroids. So here's my parting thoughts on this. So the answer is correct that most of you got. There is no maximum dose of norepinephrine, but it should be the rare time that you need it. The way I do this in my practice, if I have an escalating dose of norepinephrine, once I get to that 0.2 to 0.3 micrograms per kilogram minute, I'm usually starting a second agent, vasopressin, and I'm starting stress dose steroids, hydrocortisone, and I'm assessing those causes. Now, if I need to add inotropes or other agents, I will do that based on the assessment. So there you have it. Norepinephrine, how high can you go? Please leave me your thoughts, comments, and questions, and thank you for tuning in. Until next time.